All right, welcome everybody. Thanks for being here with us today. We're excited to get to talk to you a little bit about the faith integration component of SBIRT. And my name is William Woodney. I teach in the psychology department for the undergrad students here at Azusa. I teach with Rachel and Dr. Lehman. And I'm just going to hand it over to Dr. Lehman. He's going to start us off with talking about some of the faith integrated SBIRT challenges that might occur.
Yes, and I am the man on the film. I am the therapist, if you didn't connect it, but thank you. Got a fan here. Good morning, and so what I have found from working on this project, what I found from working on this project is that for nurses and social workers, there is an immediate excitement about SBIRT. It meets a need, it fits within their model, and it clearly just, they're on board right away. Psychology and my trainings as a clinical psychologist, I think I understand it, but we're a little bit more hesitant to get on board with this. And that may not be the case for all of you, but there's a possibility that it is for some of you. You're thinking of maybe a traditional therapy session and saying, well, how does this fit into that? And so we want to, in part, unpack that today in our section here. But we're also going to do a introduction to some of the faith integration that occurs in the training and talk about that. So the big picture here is we talk about how do you supervise well to help psychology students implement SBIRT in their work in your supervision of them, and also do that with a faith integration component. To start off, effective supervision of SBIRT is challenging, and perhaps more so when integrating faith and spirituality. When you're trying to teach a student how to do SBIRT, there's some specific components. There's steps, absolutely, but sometimes students don't always remember those steps. Sometimes they get nervous. Sometimes they get, kind of lost in the process. So just getting them acquainted with the steps is part of the learning process. But then also doing it in a way where they have an ear for faith and spirituality issues and know how to work with those faith and spirituality issues. That's perhaps even more challenging. And so we want to talk about that. The big picture for this presentation was sort of the Bronfenbrenner's ecological perspective. So I was thinking about all the challenges in supervision. So the challenges can be, of course, individual. So overcoming their resistance or lack of interest. Maybe they don't see this as relevant. They're passionate about eating disorders. They're not sure how SBIRT fits into what they want to do. Then there's microsystem challenges. Challenges in particular, if you're thinking of supervision, challenges in the supervisory relationship. Mesosystem being sort of the agency challenges. We know that even if you leave this training, we're sure you will, extremely excited about SBIRT. We know that sometimes it's hard to bring in a new intervention, it's sometimes hard to walk away and actually implement what you've learned. So we want to talk a little bit about that. And then finally, some of the cultural and macro system. In particular, sometimes religious barriers. And we want to talk about religion and spirituality as potentially being a resource for change in substance use. We know that the research shows it tends to be a positive, but there's also times when it can be a negative. It can be a barrier, and so we'll talk about that.
Great. So we have an overall purpose today. Basically, what we're trying to do is to help and equip allied healthcare professionals such as yourself to view things from a biopsychosocial and spiritual model. This isn't necessarily something that's going to be new, but the spiritual component might be something that's just a focus and perspective that we're going to concentrate on to give you some more insight to that. Our specific aim today really is to talk about supervisory skills based on motivational interviewing. We'll talk about some specific questions that you can ask related to motivational interviewing, some solutions for systems level barriers, and then some tools to leverage spirituality and address barriers and biases. So that's kind of where we're going today, just in a brief nutshell. And Curtis here is going to talk about our biopsychosocial model and talk about, Curtis, how do we incorporate spirituality into this?
Of course, yeah. So of course I'm assuming that we're all, and all of you are psychologists, is that correct? A couple of you not, but those of you who are therapists, I'm sure you're familiar with the biopsychosocial model, right? So the biopsychosocial model argues that people are multifaceted, that we exist biologically, we exist psychologically and socially, and those are not mutually incompatible. They actually coexist at the same time, and so we experience our psychology is reflected, it exists in our biology, but we understand that it emerges. There's properties that emerge that are different and can be understood differently at the psychological level. And then at the socio-cultural level, there's, of course, relationships with other people and systemic factors that play into things like substance use and things like mental health issues that influence us. And that doesn't mean that the brain's excluded. It just means that those things are probably impacting the way people think and probably impacting the way, impacting their body and impacting their brain, causing them to have more susceptibility to mental health issues and substance use. So that's been well established. And again, we don't say that these are Venn diagrams that are like not overlapping. They're actually fully overlapping. They're existing at the same time. But what I think is helpful is also introducing a spiritual component to the biopsychosocial spiritual model. And spirituality, we know, is, again, a cultural, linguistic need that APA has recognized is something that's important for us to be competent with and be able to work well with our patients and our clients. And it's also, in this light, we recognize that it doesn't have to compete with explanations for why people have substance use problems. It can be an alternative perspective that maybe just informs our perspectives, that maybe deepens it or broadens it in some ways. And it's also a critical skill for just being able to communicate with your clients, is being knowledgeable about spirituality and how that informs or how that might intersect with things like substance use and mental health.
Great. So we're trying to give you kind of a holistic picture of how we're kind of approaching it. But you all are really out on the front lines. I'm interested to know maybe what are some of the challenges that you all might have in incorporating SBIRT in your agency or setting. Maybe you do it already, maybe you don't do it, but you have enough background to know kind of what it's about. What are some challenges that you all might find when integrating either the faith component or when integrating just SBIRT into what you all normally do?
So I'm aware at our community counseling center that there are already about a gazillion forms that students have to get through. And as a supervisor, one of my concerns is that they're so busy doing forms that they don't actually engage with the person in terms of why they're coming and what their presenting problem is, what they're motivated to talk about. And I actually think that the forms sometimes get in the way of establishing that first bond or attachment. So my first thought is, oh gosh, here's one more thing to have to go through before you really jump into what brings them into the therapy setting.
Thank you. I've had clients come to my practice and talk about going to other agencies where they said that the therapist just took notes the whole time and never even looked at them. They were just so busy going through all the forms. So that's right. So it could be a barrier if it's just another form that's filled out and we don't attend to the actual person that's in front of us. Thanks, David. What you all talked about was so important because we can have the program and we can have the ideas from SBIRT, but really it's the contextualization that you as a supervisor are responsible for in so many situations, right? No one client is the same, no one issue is the same, and it's this contextualization of SBIRT that really is a challenge. So thank you so much for sharing that. Curtis is going to briefly talk about some of the cultural challenges and other challenges that we might find in responding to SBIRT.
We're hoping that we could touch on some of those concerns. Some of them we don't necessarily touch on, like the issue of the burden of paperwork and more assessment tools. But we wanted to present at least a framework for you guys to kind of help navigate some of this. And it's absolutely, we hope that this is done individually according to your treatment setting. And so we know that, as Dr. Castaneda shared, substance use is a huge problem. It's not like it's a small fraction of the population that you might be working with. So, so if knowing that, we know that it should be prioritized somewhere, but having to try to figure out, do they have the capability with brain injuries to comprehend and have insight into that? Do they have, how much of a priority is it if they're coming for PTSD treatment? So it is a challenge. And so I encourage you, as we're presenting, to kind of just think it through. And if you want to ask some questions, and others in the audience, you guys are all professionals, so if anyone wants to contribute some ideas or solutions to someone else's challenges, that would be welcome as well. So. So again, using Bronfenbrenner's ecological model, starting with the macro system or the cultural level, and saying, like, at this broad level, what are some of the challenges in terms of doing SBIRT? And we think that there's cultural factors, and that culture, of course, involves the therapist and their attitudes towards it, as well as, of course, the client. But we think also that the agency tends to have its own culture. The agency says, well, we have our mission, we're passionate about our mission, we're excited about it, and they have practices that they engage in terms of the paperwork they have or don't have. They have the different procedures, and those are obviously very important, very essential to their identity. And so sometimes people can dismiss the idea of, like, SBIRT and say, well, it just doesn't fit with our mission. It's not aligned with it. We're not even going to explore it because it's going to be a deviation, or it's going to be too challenging to figure it out, or some other factor like that. So we think that SBIRT can be a part, not of your mission statement at your agency, but it can help you fulfill your mission statement. Because if you have someone who has PTSD and they also have a substance use disorder, that's going to contribute to their problems, and that's going to be an impediment towards their recovery. I know there's a lot of theories in terms of where substance use disorders and trauma kind of intersect, and which one you should prioritize. But SBIRT at least starts that conversation where you can say, oh, I didn't ask, and well, you don't know if you don't ask. So if you do ask and you realize, oh, wow, you didn't bring this up, but you're sharing here that you're using, meth a few times a month, there can be things that pop up that we just have no idea. Like the person in front of us, we just have our presuppositions about how they live their life, and without asking, sometimes those things just don't materialize for us. And so asking is critical, and we think that your ability to treat people with eating disorders or people with brain injuries can in many situations be helped. Of course, not in all situations, but in many situations can be helped by utilizing SBIRT, knowing that it's such a huge health problem across the United States. And then, of course, there's the other concern of, well, we're psychodynamic, or we're existential, or humanistic, or we have our treatment, and sometimes there's this opposition to evidence-based treatment. So that's challenging, but I get it. I appreciate the psychodynamic theories and the way they broaden my understanding, but I also think that personally I value evidence-based practices when I see that they can lead to change. And so I think in particular, motivational interviewing is so individualized that some of the critiques people have about evidence-based treatment, about it being manualized, this really isn't manualized in that sense. There's some steps to it. There's a guided process, but it's not, it is very open to the conversation that emerges with the person that you're assessing and that you're working with. And I think that is huge, that you don't have to feel constrained by it. And you can have, like the video shows, some interesting interplay that can happen where you feel like you're doing some Jedi mind tricks with the person. And I do think that's part of the standard of care. You want to meet them where they're at. And sometimes that means some flexibility in terms of your preferred style of treatment. And of course, I just want to name it and say that therapist culture is also a factor. Having negative biases or being naive about substance use can be a role. That's a much bigger topic, but want to at least touch on it here.
There is a potential for the client or therapist for the therapist or psychologist to have biases about addiction that causes them to see or not see certain things, right? This is something that's very familiar to us in the sense that we understand with APA and cultural competence and this idea that we want to inquire and understand a client's story, a client's background, instead of making presuppositions, instead of coming in with already viewing someone a certain way. In the same way, we have to understand that faith, the research shows that faith, religion, spirituality also has potential to produce certain biases on how we view substance use. So a trainer's own self-awareness regarding personal attitudes towards substance use, particularly as related to his or her religious spiritual background, and we're speaking broadly here about religion and spirituality, will enable students to understand their own beliefs and potential biases. So one of the things we do stress as we do these trainings is that it's important for our trainees, the people who are doing these interviews, to understand what biases they might potentially have towards addiction and how religion or their own spiritual beliefs might encourage or enable them to have some of those biases towards substance use. So each religious tradition brings unique resources. They can also be associated with negative perceptions, okay? So attitudes of both the patient and the healthcare professional towards substance use, attitudes towards recovery and treatment. So this is important. We see the twofold nature of it. The patient or client can have biases towards how religion and spirituality view their addiction and treatment, and the therapist can have their own, right, biases. I mean, this, when we think about it in a transferential type way, that's what we're talking about here. But we have to understand that those biases can go both ways. And so the process of role play, which can supplement the SBIRT training, is likely a valuable exercise for decreasing some of these biases. We'll do some of these questions that we do with students later. If it's helpful, great, use it. If it's not, no worries at all. But one of the things we do is try to have people identify some of the biases or even resources that religion and spirituality might be in towards substance use, and that becomes a way of developing their own self-awareness. And then if we could go back to that other slide real quick. We have some religious biases that I'm just going to mention briefly that tend to judge instead of support. These are found broadly across many different religious traditions, but Azusa is Christian, faith-based university. So these are some of the ones that we run across that students might have. So the idea that if this person was really serious about their spiritual life, God would heal them in relation to substance abuse or use. If a person was committed to prayer or Bible study, they wouldn't need to use drugs. If they were really saved or part of being one of God's children, they wouldn't have relapsed. So we have to understand that also students that we're working with have a great potential to have some of these biases towards the person that they might be working with. So then our goal really is to train students to see people from this holistic perspective. Students, at least as we work with them, and I don't know what you find in the students that you're supervising, but one of the goals we always have is to just broaden their perspective of how they view the people that they're working with. Because sometimes it can be so narrow, and sometimes it can be very simplistic. And when we explain that substance use especially can have biological, cultural, social factors, it begins to broaden this perspective of how they might actually view the person and the factors that led up to their substance use.
So moving now from cultural to systemic challenges. As you mentioned, there are some issues in terms of, well, how do we fit the paperwork, the screening tools, the assessment tools that SBIRT provides? How do we fit that in? How do we ensure, just in terms of detail, how do we ensure that the clinician reviews it? The worst thing is to have an assessment tool that nobody looks at, right? So that's a detail that can be a challenge, and then how do you ensure that they review it with them while still making eye contact and being able to track emotionally what happens in the conversation is another.
So Curtis, you're saying maintaining eye contact is something that's important when having that conversation.
Yeah, I think so.
Yeah, great.
A system challenge. How do you provide good quality supervision? Just do it. Just go out and do SBIRT. Okay, you did the training, great. Go ahead and do it. That unfortunately, I know some of you, it's kind of intimidating to say like, well, how am I going to supervise them on? Just telling them to do it is not going to be enough. So there is a sort of a higher standard in terms of what will be required of you, as you might expect, that you'll have to be familiar with doing SBIRT yourself, but also you'll have to be able to kind of monitor their progress and do some of the fidelity checks that we'll help you with. We've got some of those to help them, to help you evaluate their competence with SBIRT. And then finally, in terms of referral to treatment, so it's screening, brief intervention, and referral to treatment. In terms of a systemic challenge, it's hard to know where do we send them. They have a problem. They have a significant problem. We're not the right agency for them. The majority of the clients that you will have when you screen them, that won't be the case. They'll sort of self-select in the right treatment facility, but sometimes not. And so sometimes they'll come to you and think, oh, well, I've got huge problems. My life is in shambles, and I'm going to go for PTSD treatment, but they actually have a substance use problem that kind of overarches all their other problems. And so sending them to the right provider is challenging. I'm just going to note that there is a free resource from SAMHSA called TAP 33, Treatment Assistant Publication 33. To get it, all you have to do is go on SAMHSA's website and download it. And I'm letting you know that because I'm stealing their guidelines here. So what they recommend in terms of implementing at a system level SBIRT is, first off, you want to engage as many staff as possible, okay? So many of you have varying size clinics and agencies you work for. So some of you, that's going to be, oh, it's just me and that person, and that won't be too challenging. But others, it might be a whole team of you, and it can be very challenging. But if this is something that you really feel like would be of value at your setting, don't just try to do it on your own. Engage them in the process. Help them become familiar. Ask them to do the training that we have available online. Get them as comfortable and knowledgeable about SBIRT as possible. Assign clear roles. That might mean one person is a specialist, an in-house specialist on doing SBIRT, and they do SBIRT with everyone who comes in. Or it might mean, again, depending on your setting, that you have supervisors that are general specialists, and so all of them will be trained in SBIRT and will be familiar with how to do it. Again, that depends on your setting, what works for your setting. Develop a staff training plan. So how do you train your staff? Select screening instruments. We're going to give you a number of them. Some of them aren't going to make sense in your setting, like If you don't work with adolescents, obviously don't use the craft, but select the right one, the one that will inform you and help you the most, and then develop referral procedures. So figure out, again, where those quality providers are in your community, and figure out how you're going to do that referral, including some of the details about how a warm handoff could actually occur.
Great. So we have some ideas here about how also SBIRT can be effective in your setting. The first one here, it's evidence-based, so it's supported by research to effectively identify and help substance use at-risk issues among individuals. That's something that you've already known, we've already mentioned it, but it is an evidence-based practice. One of the advantages that we have is that it's brief, so it takes no more than 5 to 15 minutes to really complete. Yes, the video took a little bit longer, but you can speed it up. And so it's a quick way to find out about a client's substance use and a quick way to briefly intervene. It's cost effective. And then it's also valuable. It's important to identify and address substance use issues early before they become more serious. And I think it's also, again, from this kind of holistic or developmental framework, it's really helpful to understand how substance use might play a particular part where a client is developmentally, right? So to understand the social and cultural issues that are going on for them at the time and how substance use might play a part of that is a way that can be a valuable resource to help identify what those issues are. Sometimes, again, thinking about working with students, right? A client might come in with a presenting problem, and because that's the presenting problem, right, the therapist might not ask about other related things that could be either related to substance use, family cultural things, social things that are going on in school, so forth, right? And so our goal, hopefully, as supervisors is to help broaden that perspective of all the various things that could be going on and to try to make some room to understand that. So it can be valuable in that way.
A few other advantages in terms of, again, we're trying to sell you a little bit on putting SBIRT into your setting. In terms of getting quality trainees, often they are attracted to certification. So pointing out that if they come to your setting, again, at APU, they would already have the certificate, so it might not be that attractive. But of course, you're likely recruiting other students. And so saying that as part of your training, we're going to certify you in SBIRT. That's one of those things that gets those quality students to come your way. So that's a good marketing tool. A few other things are just having good assessment tools. So again, SBIRT embeds these assessment tools in it. And as many of you are psychologists, I think all of you, or most of you, really appreciate the role of assessment. That having good tools to determine people's level of risk and level of vulnerability in various ways in their functioning can really inform the clinical practice. And so SBIRT just provides that for you. The other factors are, and this is in regards to the training. So there's this 4-hour training, all web-based, great material. They did a fantastic job on it. It also introduces you to the substance use disorder continuum of care, from outpatient all the way into inpatient hospitalization programs that are available. And that helps the therapists get a better sense of what is occurring. And so, again, for trying to refer people to providers, knowing that you don't refer someone with a moderate use problem to an inpatient care facility may seem kind of common sense, but sometimes if you don't know to look for that difference, it doesn't always become apparent. One of the things that students are always fascinated by is just knowing more about drugs, and the training provides some great quality education about drugs to help them be more familiar with it, more, again, competent. It's kind of, if you don't know, it gets to be kind of scary and kind of just mysterious. But as you learn about the classes of drugs, it just makes them more comfortable. For psychologists, for nurses, the training on brief intervention is huge. They don't have that kind of clinical therapeutic intervention training. For psychologists, your trainees and of course you yourselves, it's not going to contribute a whole lot. I mean, I love motivational interviewing, but you guys probably have good clinical skills already. So I think that's less of a need for psychologists and psychologist trainees. But again, I think the bigger picture of all these other factors contribute. And I think, again, I love motivational interviewing, feel like it's informed my practice. And so by just kind of giving that extra education on it, it might, again, sharpen their skills a little bit more to help them kind of think critically about their clinical work. And of course, we've already mentioned just giving them a cultural framework in terms of how faith and religion and spirituality fits into a person's recovery from substance use is also helpful. And so in terms of supervision, okay. So once you get past, and they can be challenging, once you get past the how do we find good screening tools, how do we implement them properly, and then how do we find good providers in the community, and how do we do a good send-off of the clients so that they get connected there. So once you handle the S and the RT, you have the BI in the middle. And the brief intervention is where you as supervisors have your primary role. Okay, you don't have to supervise them about how to give out the paperwork. Maybe you give them a little bit of supervision in terms of making a good referral, but really the meat of it is how do you get them to have a quality, productive conversation with a client that leads them to change and decreases their risk for substance use problems. Brief intervention is always individualized, and so that clinical skill, bringing in all the other training that they have, is about when you have supervision, you help them recognize the ways that this could be individualized and the ways that it could be tailored. We've got some supervisory challenges. We heard earlier, there's an assumption of video recording.
Well, just video recording, or the idea that now what the APA is requiring, that they're having some sort of direct link to be able to see either through video or a two-way mirror where you can observe. So how do we assess this? I mean, basically this idea that moving towards this direct contact with being able to look and watch someone while they're performing SBIRT, giving them the tools to be able to do that, and then being able to observe and give feedback would be really helpful for students as they're embarking on this practice. So really, right, when we go through training as clinicians, it's not just knowing the right things to say, but it's developing that piece within us where you're able to sit comfortably and to do these things and to own them for yourselves. And a lot of times in supervision too, what students report isn't always exactly what exactly happens, right? And so moving towards to be able to do this with the new APA kind of requirements is a way that, well, not only you can work in supervision to make sure SBIRT is implemented, but you can work on some of these other skills like empathy, resistance. There was another one I was thinking of, but just implementation of kind of the SBIRT practices. And
oftentimes with supervisors, it's like, what do you supervise? What do you review with them? You can't watch it all. The brief intervention is a great thing to supervise. You can witness a sort of encapsulated intervention that they have. It shouldn't be too long, shouldn't be more than about 15 minutes, and could be a great piece of information in terms of their broader clinical skills. And so, again, implementing it could mean that you get a very an evidence-based practice that you can evaluate with our tools and be able to go over with them so that it's kind of very objective in terms of evaluating how well they're performing it. So.
Sure. I think it's a great snapshot, right? Because there's a lot of clinical tools included in SBIRT that we want to develop in students, like empathy, like working with resistance, that you can get a really quick snapshot on in 5 to 15 minutes if they're doing the SBIRT practice, that not only help understand to develop this SBIRT framework, but also help to develop their clinical skills kind of overall. So.
And since we've mentioned it a few times, in your packet, in your folder, there is a brief intervention fidelity evaluation. So that's what we're referring to. So in overcoming this supervisory challenge, we're trying to provide the tools for you to be able to supervise in a particular way how they're doing with the brief intervention and SBIRT more broadly. So walking through this, again, one of the concerns is with supervisors, if you provide some negative evaluation, I mean, this is a very objective, very clear-cut, like, oh, did they identify the risk level? Did they ask them for additional information on their use? There's very clear-cut where you can just evaluate, walk through it all, and it doesn't have to be a huge burden on you. We know your time is limited, and it's challenging to do more and put more on your plate. So the team has come up with this as a helpful guide for how to do that video recording supervision.
Great. And so just real briefly on the idea of developing trainees, developing interns, this idea of faith and spirituality, how do we work with it in kind of the SBIRT training, is sometimes our trainees, sometimes our interns have difficulty bringing up things that are difficult for them. So religion and spirituality is one of those things that we don't oftentimes ask about in polite conversation, just like generally people, they don't talk about sex, they don't talk about politics. There's this kind of taboo around things related to religion and spirituality. You don't want to impinge, you don't want to offend someone. And we need to work to develop therapists who are able to have a peace in themselves where they are just comfortable about asking about these things. So it's difficult to ask about in related to maybe a client in relation to substance use or their own faith, how that might play into their substance use. But to be able to ask about it in a way in relating to brief intervention or motivational interviewing is a nice way to be able to enter into those subjects. And what I mean by that is having an open and empathetic stance, being able to ask questions, not telling, but just evoking a response from the client or patient is a way that we can think about doing that.
We're trying to embed this faith and spirituality. How do we do that well in the context of SBIRT? So again, this is adding that additional challenge of how do you add in effective conversations about faith and spirituality when you are doing this assessment, this intervention, when you're doing SBIRT with the clients you're working with. Okay, so how does faith and spirituality integrate? Like, do we just kind of say, oh, you students, you should care about substance use, and it's not just about health, it's also about like spiritual wellness? Sure, that buys them into the process. But we think also that faith and spirituality and competent conversations about it can facilitate the change process. We think that by being able to have that ability to comfortably, and appropriately talk about their spiritual and religious beliefs and convictions and resources, that can actually help them say, oh, wow, there's something in this that isn't aligned with my values. And we know people don't always behave in line with their values, but helping them have a non-judgmental conversation about their beliefs and their behaviors can really facilitate that process. So in particular, we have 4 steps of the brief negotiated interview is these 4 steps. Raise the subject, just say, is it okay if we talk about your substance use? Provide some feedback. They had already done the screener. You just say, based on national guidelines, your use falls in this range of risk. And then really the crucial aspects are the last 2. Enhance their motivation, use the MI procedure, and that might be what's good and not so good, and what's the readiness ruler. On a scale of 1 to 10, how ready are you to change? So where can you use faith and spirituality? It could come in with enhancing motivation. We know that, again, people's values are sometimes not lined up with their behaviors. And so by having a conversation about their values, that could actually kind of facilitate some change in those behaviors like substance use, alcohol and drug use. And then you say, well, you know what? Alcohol, I'm kind of leaning on that, and I'd like to just develop my relationship with God more. That's a great motivation for them to change, and it decreases their risk. It's sensitive to their culture, their spirituality, and so having that conversation can help them. And in terms of being ready to change, just believing in the power of their religious support, their religious community, and even just their perceived support from God, that plays a role in terms of being ready to change. So we think that faith and spirituality are very important for many clients, not all, but many clients. It can be very important for that motivation to want to change. And then it can also be an important role in the plan for how to change. Because oftentimes people will say, I'm going to start going to church again. Simple enough. That could be part of your negotiated plan with them, is for them to say, yeah, I want to get involved in my religious community again. I've kind of dropped out. And if you are, again, uncomfortable talking about faith and spirituality, you might not want to say, oh, that's part of your plan. You might be like, oh, well, I'm not sure if that's going to be helpful. But if you just simply kind of acknowledge that they're trying to figure this out, and they think that it's going to be helpful, if you just can have that conversation, you're really going to help facilitate their change. Okay, great.
Let's talk about how it might fit into motivational interviewing. So the spirit kind of a motivational interviewing is to present this way of being instead of a particular technique. So, of course, it is given through the particular questions that you asked, but it's also this warm, empathetic, and genuinely unconditionally accepting stance. So this is a way that we approach how to incorporate aspects of religion and spirituality also into SBIRT training and SBIRT interviewing, in the sense that we want to try to understand, is there a way that a client perceives substance use in connection with their religion or spiritual communities or faith? So understanding then, how might their religious community view their substance use? Is their religious community supportive, or do they judge? What do they think their reaction from their religion or spiritual community might be if someone found out about their substance use? All of those things are a way to identify one of the two things that's very important with faith and spirituality in SBIRT, which is to note if religion or spirituality is a resource for this client, or if is it a barrier for this client? And those are those two kind of hooks that we'd want to leave you with today. Is it a resource or is it a barrier? And those are the things that we determine during the motivational interviewing process.
If you are comfortable talking with them about their spirituality, you can really leverage their religious and spiritual community, beliefs, coping resources, and that can help them in that process of seeking out treatment or change with their substance use. So I kind of outline it. So my research area is the psychology of religion. So I'm very fascinated about some of this stuff. Religion is not just unidimensional. There's components to it. There's different factors, and it's complex. So this kind of gives some basics about things that you can look for. You can look for beliefs. So beliefs might include, God. My belief in God and a higher power is that He's loving, forgiving, caring. He wants me to grow and change. Those are beliefs that we'd probably all say that those are positive beliefs. Those for many people will lead them to a desire for growth and change and improvement. So those are beliefs to have an ear out for when you're having that conversation, to reinforce and reflect and summarize back to them so that they can draw upon it and say, okay, yes, this is something that I have available to me. Kind of builds that readiness, builds that confidence in their ability to change. Then you have practices, prayer, meditation, community service, those can all be leveraged for treatment. So again, like I said, just talking about, oh, they want to go back to religion, to their church. Well, that's a move, that's a step. We can reevaluate if that's helpful the next time we meet, especially for psychologists who are often meeting with them like weekly or so. So you can test it, you could put it out as a hypothesis. Yeah, let's see if that helps. If it doesn't, well, you can have another conversation, but the client's in trying to engage the process of change, and that's important. So let's kind of encourage them in that process. There's also things like religious coping in terms of how they use their faith to deal with problems, religious support, religious sort of perception and locus of control. So all those are things that you can have an ear out for to say, oh, well, that might be helpful. That might be something I could leverage. And then resources like financial support. Sometimes they have people in their community who are willing to give them money, loan them money for treatment, or for trying to get out of a neighborhood that they shouldn't be in. They might be able to provide them with some housing temporarily. So there are resources that we may not be like, oh, traditionally, we don't know how to help them out of this. If you think about their faith community, there might be some resources that could help them. And then I have some others there.
And I think that just to footnote that, Curtis, I mean, those are kind of the theoretical components, right, of maybe what we're trying to get at. But just giving students a question to what to ask and how to enter into that to draw those things from the client are really kind of the key things that are hard to know how to do, and the things that we can equip students with, or our trainees or interns, So the question's up there, but basically, do you have any religious beliefs or practices that you draw strength from? That's a way to enter into that conversation. Are there any resources that you have from your religious or spiritual community that help you have strength, or you draw strength from? Is the Hope and SOP in the packet as well? No, Hope and SOP or not. There's some resources, though, on the website. Two of them are called the Hope and HOP and the SOP, SOPP, that give you a list of questions similar to this that are a way to enter into some of these areas of belief for the client that might evoke some of these ways of how religion or spirituality might be a resource.
The SOP is the SOP, like MOP. The SOP is the tool that Department of Mental Health in Los Angeles County uses within all of their service contracts. And so that one it's very brief, and it stands for, I'm going to find it during the lunch break to show you, because we didn't include it just in case you wanted to use it as a resource to have those questions to kind of ask or think about in addition to this one. And then the HOPE is used in medical settings, more so.
We have some questions. Just turn to the person next to you. We want you to kind of try some of this stuff out on your own. And if you developed a substance use problem, are there any religious or spiritual practices that would be helpful for you? Just turn to your partner, answer that question. If you get through that one, go to the next one. Is there any way your faith or spirituality might be unhelpful for substance use problems? So just turn to the person next to you and take a shot at either of those. Now, we do want to acknowledge that some of you are in areas where you're working with students who do have faith backgrounds, and there might be a diversity of settings here. So we acknowledge that. That's perfectly fine. If you're comfortable, go on and tell us what you came up with on the first one. If you developed a substance use problem, are there any religious or spiritual practices that would be helpful for you?
Okay, so I would say community, and I say this a little bit tempered because I would want to make sure that the community was as non-judgmental, accepting, and empathic as possible. And I think also there are various churches that have some sort of Celebrate Recovery type spin that works well for them, but I could see how that could easily turn into something that is not as helpful for somebody, especially if they're getting a lot of judgmental messages. And I think just the structure a lot of times associated with religion or faith institutions can also be helpful, because a lot of times people use substances because they don't have anything to do socially, or maybe there's boredom, so it adds a little bit more, I guess, motivation to socialize with other people. That was me.
Great. So community,
Yeah, thank you.
community, the structure, maybe some of the programs that the church may have. Great.
Yeah, and the psych of religion literature too. That's social support is one of the biggest factors of the helpful benefits of religious community. Good. Others?
Yeah, I've heard people share that they are thankful for having an addiction because it helps them in discovering a calling and in connecting with God. So absolutely, just kind of giving a chance to think broadly about their the meaning they make of the problem they have can be really fruitful.
And just to summarize that for our audio recording, but no, it's fine. Basically, the comment was that there's a way that a religious faith or community or practice can help a client be reflective on maybe the practices and how those practices might be incorporated into the way that they think about the meaning of what's going on with substance use. Did I do that accurately enough? Okay, great. Thank you very much for your comment. A gentleman was talking about how sometimes students from programs, maybe or maybe not from even a place like Azusa, can lack a degree of religious and spiritual competence and even knowing what a client might be talking about when they bring up religious or spiritual matters. Did I get that right? Okay, so right. So if the people you're supervising have a discomfort or just not knowing what to do with it, that definitely can create some barriers to even a comfortability on how they empathize maybe or how they ask the questions. So thank you very much. You were going to say something, yeah?
And I think, well, there is a trend, obviously, with SAMHSA funding a project like this for including faith and spirituality as a diversity issue. But historically, it's been left out, and we've honored ethnic and cultural diversity. We've honored, gender and sexual orientation, but not necessarily people's religious and spiritual beliefs and practices. And I think that's a shame. I think there should be more of that in clinical training to get people equipped to have conversations, not necessarily where they know all the ins and outs, but at least know a framework that can help them talk about it. So.
And just to footnote that too, I mean, in the psych of religion literature, some of you might be familiar with it, but culture is oftentimes connected with religious or spiritual beliefs, right? So the two we can't parse them out so neatly. Like this is cultural competence and this is religion and spirituality. Very, very often, as the literature points out, they're inextricably intertwined. So good.
This is actually a helpful conversation to have with your students. So if you wanted to implement it, it could be helpful. Just helping them talk about what might be helpful, what might be unhelpful. You do that when you're in supervision, and that could potentially, again, building that comfort with having the conversation is so crucial. And you can only do it by having them, they may be completely comfortable talking about it in their church or in their mosque or their faith community, but totally different, a professional setting may be very different. So bringing that comfort into that setting is important.
Right, that's right. And it really, I mean, the gentleman's comment in the back made me think about the importance of this, because if a trainee intern is unfamiliar with religion or spirituality, and they're unfamiliar to the point where they're just uncomfortable of asking the questions, it's going to limit the responses that can be evoked from a client, right? And we all talk about transference and supervision. So a barrier within us has a potential to create a barrier, even unconsciously, well, if that's your orientation, but anyway, even unconsciously on what is evoked from the client, right? So I think that those things are just really important to consider, that being able to understand what potential biases that the intern or trainee might have, and how it might function as a resource or barrier for them, clues them in onto some of the transferential interactions that might actually occur with the client that they're working with. So that's basically what we're talking about here. As supervisors, we need to recognize that helping students become comfortable discussing faith and spirituality will be facilitated by their own comfort and ease with the subject. And so part of kind of what we're doing here too is that as we talk about it, hopefully we're creating a degree of comfort and awareness in us that we can pass on towards students, because again, things that we don't talk about, we talk about parallel processes in supervision, right? And so some of the things that we also don't talk about or do talk about will manifest itself in the ways that trainees, interns work with clients. So.
And it doesn't require a lot of sophisticated knowledge. It's great when that's available, but oftentimes just asking open-ended questions, and you could do that with the supervisee, and hopefully they'll also do that with the clients they work with. And just asking those questions doesn't require, I mean, there's always, when you're talking about culture, competence, part of it is being open to having the client teach you about their background and about their values and what's important to them. So that rings true for faith and spirituality too. One of the tools that, so those open-ended questions, so part of this is like, is this really gonna fit with SBIRT when it's only a 5 to 15 minute conversation? One of the tools is of motivational interviewing is the are the ORs. The ORs are open-ended questions. One of the tools is the ORs, which is open-ended questions, affirmations, reflections, and summarizations. You can do that when you're having a conversation about substance use, and that's encouraged. That's part of the BI, the brief intervention. But you could also do that when they're talking, when the conversation transitions where they might talk about their faith and religion. You can use the ORs in having that conversation. Again, asking open-ended questions, affirming them for their religious practices. That may feel, for some of you, a little uncomfortable, but for having that conviction and trying to live in accordance of that conviction and trying to find meaning in their life, those are all things that we can affirm people for, that they are engaged in the process of trying to find meaning. And that is so, well, I think it's so important for human beings to engage in that process, even if there's not a clear answer, and to persist when there sometimes isn't a clear answer. So the ORs, you can use that, again, to leverage their faith. We're talking mostly at this point about some of the positives, and saying, you know, summarize and affirm and reflect back when they say something positive that you think is a good thing that will encourage them in the process of change. So use the tools for substance use, and if it comes up, and sometimes if we, sometimes it's valuable for us to help direct the conversation in this direction, but when spirituality comes up, use these tools for that as well. And so this can be helpful for you. You could share this with your students if they're interested in integrating faith and spirituality. And so it can be helpful for them to, again, kind of illustrate what the ORs look like in a little bit different fashion. Usually you would see it in the fashion of you ask questions about substance use. So